Despite all of our modern inventions, modern medicine, cardiovascular risk still remains the number one killer of Americans. And overall, it's not very fun to treat or talk about. You can't feel it, you can't see it. And so I want to dive a little bit further into discussion on how to take care of your heart, how to prevent the first event, what we need to look at. And Coulter Salmon is the newest nurse practitioner here at Live Oak, and so we're kind of developing a preventative cardiology look and taking an integrative approach instead of just throwing prescriptions right off the bat, looking at lifestyle, environment, other metrics that can help move the needle in terms of overall cardiovascular health. So I wanted to bring him on board and give us some insight to his views and dive into it further. So thanks for coming on.
Yeah, thanks for having me.
Can you just give a background on yourself as a nurse practitioner personally a little bit?
Yeah.
Get to know you.
So the last 5 years, I've been in an interventional cardiology practice. And even before then, I worked more so in a gerontology type environment with post-acute care and long-term care. And then as a nurse, I kind of found the passion for cardiology in the ICU and flight nursing. But through all that, I kind of saw where maybe the traditional guideline-directed Western medicine pathway was kind of lacking in some ways and pursued functional medicine.
And so you've done specific functional med integrative training, and then did you implement that alongside the traditional cardiology route? Is that possible, or was it?
So all my patients benefit from my coaching, I guess. I can't help but tell people that, hey, there's, you can do this instead, or maybe this will help, or you have these symptoms, you ought to consider looking at this. And so it's kind of inseparable now from who I am.
Right. So, I think cardiology is great, especially interventional cardiology and everything, but really our goal, and for the most part, they show up at the cardiologist's office, 20 years after things needed to be changed, 10, 20 years. And so what I want really for Live Oak and to, just talk with people about is like, what do we need to be doing, let's say now in our 30s, to help prevent that first event in the 50s, 60s, and what do we need to be looking at?
Yeah, so I don't think people really realize that you start working on that heart attack or working on laying down the plaque in your arteries or just the endothelial or inner lining of the artery dysfunction. You start working on that in your 20s and 30s most of the time. As far as what we can do to be more proactive, obviously there is checking cholesterol and some diagnostic imaging or like coronary artery calcium scores. We can use those earlier and stratify risk. But I think one of the best metrics really is your functional capacity. How, in shape are you? What is your cardiorespiratory kind of capability? And we can measure that with like VO2 max would be a good metric to get you a hard number that you can work to improve on.
What is that different from just a normal stress test?
So a stress test, I think they're really similar, but with a stress test, we're using the Bruce protocol. So you're on a treadmill, and at this many minutes, it's going to increase speed and incline.
Yeah.
And then from that testing, we can determine METs, which is a way to measure work.
Yeah.
So, but it is very similar to VO2 max.
Yeah, because I think a lot of them use actually the Bruce protocol to do their VO2 max testing. And I guess it's just, with the stress test, you're looking for symptoms, EKG changes. The VO2 max, you're measuring oxygen output consumption and everything.
Right.
So probably similar testing. Again, it's just a functional assessment both ways. So if it's happening in the 20s and 30-year-olds, what do they need to be doing? Because, kind of like I was saying, it's just heart health is just not sexy to think about or talk about, especially when you're 20, you're made of rubber and magic.
Yeah.
And, the 30s, I feel like things are starting to we're not immortal.
Yeah.
But I still don't need to think about any of that scary stuff. Like what would you tell people? When do they need to start and what do they need to be doing?
So I think the biggest thing is just realizing that we need to address the foundation, which is we need to have a regulated circadian rhythm, meaning we need to like prioritize our sleep and have quality sleep. We need to be hopefully visualizing the morning sun, and that way our brain can produce the melatonin and melanin that we need. And then from there, diet, eating a whole foods, natural diet, avoiding processed food, avoiding polyunsaturated fatty acids like from vegetable oil. Canola oil is still listed as heart healthy. Okay, so like there's a problem there.
Yeah.
And then exercise, focus on weight loss, reducing visceral fat, which is the inflammatory fat. And then not only that, but we need to take care of our mental emotional well-being. So we need to have like healthy relationships and be social, whether that's just with our family, not meaning going out and meeting new people for everybody. But I would say that having the foundation is key to prevention and covers a lot of problems.
What do you think is the biggest driver of those that start getting out of whack that starts contributing or chipping away at
like which one matters
health?
most?
Yeah.
I'm going to say circadian rhythm.
Really?
But yeah, and because all of our bodily processes run on a clock. If we're under blue lights all day long, we're being told it's noon. Our body is timed to do these things at these times. If that's not happening, then proteins don't get folded as efficiently, or enzymes don't work as well, things like that. So I would say it's the most important, but I would very shortly behind that would be diet.
I mean, we've talked about it in the past, but ER night shift, flight nursing, probably
Right.
not the
No,
most conducive
No,
to,
definitely ages you fast. So
to heart health in our 20s and everything.
yeah.
So,
And when you're young, you're resilient, so you can get away with that for a little while. But I think it's less about like what can I get away with and more of what can I do to bulletproof myself.
yeah, I notice that a lot with guys and alcohol. I tell them is like, well, they binge drink every weekend, throughout their 20s. And yeah, again, you're made of rubber magic in your 20s. You can handle that pretty well. But then you start noticing in their mid 30s and everything, now their triglycerides are crazy out of whack. They're now pre-diabetic. They've now put on 30 extra pounds because of all these empty calories. And it's like, yeah, you were handling that in your 20s, but now, I mean, you have a family, you're not as active. You don't need to just be poisoning yourself every night, you know?
Your body needs time to recover. Not only that, I mean, there is no cardiac benefit from alcohol. Like, I heard a cardiologist say, like, life is full of indulgences, and that's all alcohol is. There's, for a long time, people were like, oh, I'm going to drink a glass of red wine to, for my heart health. Yeah, don't use red wine as your supplement for your heart.
Yeah.
And then if we're, having a couple beers every night, there's probably some toxin burden there, whether that's from glyphosate, from the hops, or whatever. Or you're also causing dysfunction in your gut, imbalance in your gut bacteria. And probably the most important is it's a pretty powerful disruptor of sleep. So you're not entering the deeper stages of sleep, and that's probably the most detrimental aspect.
Yeah, it's like one beer can keep you in just to stage 1 and 2, and like we don't get the 3, 4, and 5, the deep restorative sleep. But I want to go to just kind of blood pressure specific. Like, why is blood pressure something that we monitor, and how aggressive do we need to be with blood pressure monitoring?
I think that, some people just think, well, I just have high blood pressure, and they don't. It just is what it is. It's my genetics, and I disagree with that. I think it's a sign of dysfunction. You can have a genetic predisposition, but genetics load the gun and lifestyle pulls the trigger. So if you are having hypertension, we have some level of dysfunction. Typically, I would say there's probably some level of endothelial dysfunction, which is that inner layer of the artery. And so if you're chronically running high, let's say you're 150/90 all the time, you're causing little micro injuries to your arteries, and your body tries to fix those by taking some spackling, which is the plaque or cholesterol, and making a plaque to like kind of fill that hole and smooth it over. So it thinks what it's doing is right, kind of like when it's trying to heal a cut on your hand. But if it's happening chronically, we're building up plaque in that artery, laying it down. So it's just that high blood pressure is chronically damaging that inner lining of the artery.
From a clinician standpoint, like if I have a guy that's just running, chronically, just say 140/90, and he's like young 40s. Do I need to do any workup for that? I mean, are we getting renal artery ultrasounds or metanephrines or anything like that?
No, that would be a evaluation for secondary causes of hypertension. So I would not lead with that. I would definitely harp on lifestyle changes, addressing the foundational things that we had talked about not 5 minutes ago. If he's refractory to that, maybe see him in a few months. And if like we're seeing no change, then probably need to go ahead and help him out while he continues to work on adjusting his lifestyle. I don't think that there's any medicine that can replace the effect of lifestyle modification, but I kind of like to say that sometimes we need a Band-Aid on the way to our cure. We don't want to prevent, or we want to prevent further damage. So I would say if you're running 145/90 all the time or higher, let's go ahead and give you some telmisartan or something. I know you like telmisartan, and you've won me over. So I used to always do losartan, but
I like the PPAR gamma pathway. I mean, just from the insulin sensitivity, the metabolic benefits. You know, they're nothing crazy, but it's there, so we might as well capture that pathway. So
right, for sure. And the more you reduce that visceral fat, the healthier you're going to be. So whatever we can do to help move towards that goal. But that's kind of where I start. Now, if we are adding antihypertensives, and now we have, telmisartan, we have some hydrochlorothiazide or chlorthalidone, and now we're adding amlodipine. If we have 3 antihypertensives at a high dose or maxed out, or 4 just at all, that's generally an indication that you need an evaluation for secondary causes of hypertension. And I would say the most common reason would be obstructive sleep apnea. But the others that we do kind of work up or screen for or address would be renal artery stenosis or primary aldosteronism, bilateral renal hyperplasia. They're all addressed by spironolactone for the most part.
Okay.
But sometimes we do need to actually go intervene on a stenosed renal artery. Coarctation of the aorta. Generally, that's something that somebody is going to have seen previously on. So most people kind of know that they have that. And then one that's very rare, but that we still screen for, especially if they have kind of their triad of symptoms, would be for pheochromocytoma, which is a little catecholamine producing tumor on the adrenals. It puts a lot of stress hormones basically into your blood and jacks up your blood pressure. So
so I mean, I tell guys, like, deprescribing meds is my favorite thing to do. And so I will 100% take this off if you clean up stuff. But I've done, like, I'm more apt now to just like, hey, let's just start this now and do them both together, because I was a little bit more conservative for a long time. Be like, oh, let's just, we'll recheck in 3 months, and then recheck in 3 months, and they're like, it's just still haven't gotten around to it. And then it's like, well, okay, do you think you'll do it now? They're like, I'm going to do it now. And and then it's 6 months, and it's like, okay, well, now we're 9 months of really uncontrolled blood pressure. And so now I'm pretty much like, let's just start it now, and we'll deprescribe along the way, hopefully. In terms of reducing blood pressure, is that going to be more exercise based, or or nutrition, or just kind of everything in tandem?
Yeah, so anecdotally, I've seen that when people start doing some regular walking, if I can get them walking 5 days a week and have them watch their diet, eliminate the processed foods, decrease the oxidative stress by getting rid of the processed foods and the vegetable oil, seed oils, we will see an improvement. But ultimately, I think the improvements are probably attributable to decreasing the visceral fat, decreasing the inflammation, improving the endothelial function of the artery.
Yeah, I think walking is just underrated as a whole, just from, just getting out and moving. I mean, I tell guys a lot of times, like, I mean, my job is sedentary to where I sit and chat with people all day through just normal stuff. So I have to get my exercise in the mornings, or otherwise I get almost nothing. But just these guys that just do nothing, just getting them to walk 10 minutes after each meal. 20 to 30 minutes, of a brisk walk. And I just kind of tell them to do the talk test, to kind of hopefully be hitting close to zone 2. It's cardio that seems to have the most cardiovascular benefits, fat burning benefits. And so I like them to try and do that, which is, I mean, I think a low barrier to entry in terms of you just have to walk as long as they don't have any limitations. Then they could bike or row or anything along those lines.
Yeah, it only costs a nice pair of shoes.
Yeah.
And like a little bit of time.
Yeah.
But I'm a fan of either walk for 10, 15 minutes after each meal, or you can just lump sum it all in the afternoon if you want to go walk for a 30 to 60 minute walk. Really, we need to be shooting for the 10,000 steps a day, at least 8,000. But the more you do, I think the more resilient you are, really.
Yeah. And then, put other things with it. Like that's when you listen to your podcast or you walk your dog or you walk with your wife, make it something else with it so that it's, you feel like you're knocking out two things at once, but you're also benefiting from the camaraderie, the togetherness or just being with your dog. I mean, so I get benefits like with my dog and stuff, and so that's why I say that.
Right,
but,
and I agree with that. I would say that if you just absolutely hate walking, find an equivalent. If you would rather ride a bike, go ride a bike.
Yeah.
If you'd rather swim, swim. But yeah, do something to make it kind of enjoyable, almost to where you look forward to it. Like I don't like doing the dishes, but I started watching, whatever show I want to watch, and now I was like, this is my time to watch my episode, so I'm going to do the dishes.
Yeah.
So you can kind of play those psychological games on yourself and manipulate yourself into doing the right thing.
I have to do that to myself too. I know what I'm about, so it's like I have to try and like fit multiple things into one session so that I will do them just like that. Cooking, dishes is like I kind of do the same as like I'm knocking them out, and then you still get to enjoy it. But I think even less sexy than talking about blood pressure is cholesterol, but I think it's wildly more nuanced.
Absolutely.
And so I want to kind of just start with the traditional lipid panel. Like, what is that? What does that tell you?
Many people will say, oh, your total cholesterol is elevated. That just doesn't really give me a whole lot of value at all, to be honest. If somebody says, okay, your LDL is elevated, okay, that tells me we need to take a closer look. But is it inherently like, we have alarms going off? Maybe not. Like, we'll see. But what is your HDL? What does your good cholesterol look like in comparison? What are your triglycerides? Are your triglycerides elevated? What's your HDL to triglyceride ratio? Those things give me a glimpse into your metabolic health. And, metabolic health is one of the main drivers of cardiovascular disease and the things that we had talked about previously.
Yeah.
But that's surface level.
And
I would like to go further than that. I want a more in-depth picture of what's going on in your body. Like, can we get a fasting insulin on you, depending on your risk factors and your family's risk factors? Like, did your dad have a heart attack at 49? If so, I'm going to do an advanced lipid panel on you. I want to know, do you have elevated homocysteine level? Do you have a lipoprotein A abnormality? What's going on here?
Is there any specific number of LDL that you're like, I want to now get into the more advanced lipid panel? Or is that, like an LDL and fasting blood sugar or, something combined? Or just if somebody handed you an LDL number, does that alone make you reflex into any other further workup?
I'm probably more liberal on that than most people because I don't see that LDL being elevated by itself is the sole driver of disease, but it does perk my ears up. So if I see, somebody comes like the other day, they had like a 180 LDL. Okay, I want to look deeper. What's your metabolic health look like? And do you have any other risk factors that maybe we haven't checked for yet? I kind of like to make the analogy of if you are driving down the highway at 70, you have more time to react. If you were driving down the highway at 200 miles an hour, there's not a lot of time to react. So if you go with a 200 LDL unchecked, if you are having the metabolic dysfunction causing the endothelial dysfunction, or maybe heavy metals are causing your endothelial dysfunction, whatever it is, you're going to lay that plaque down real fast. But if it's your LDL 70, you're probably not going to lay it down as fast. So I think that let's test and not guess. Let's try to find out what's going on and see if it's worthwhile to panic.
Yeah, and so that's why it's so nuanced that it's like it's not the number itself that is drive or like just the LDL itself. It's kind of like the, you know, the wood to a fire. LDL is the wood, and if there's no fire, then you don't have any problems. But if you got things sparking, if you got 12 guys or 12 other things sparking the fire, and it's going to burn pretty dang hot, you know? And so now that you're like, okay, well, this guy's, you know, I want further workup on this guy. And you kind of alluded to a few of it already, but you said lipoprotein A, homocysteine, fasting insulin. What else, like if you could get your ideal panel, what else would you get on them?
My ideal panel is probably the Vibrant CardioZoomer. So I'm a big fan of that. I've done it on myself, and it was a wealth of information. It's overwhelming almost because there's so many markers, but it does, you know, more information is better than less information. So, you know, I could see me personally elevated TNF alpha. Okay, so like, and that's probably mediated from a little bit of gut dysfunction. So let me work on that. So it gives me a lot to kind of think about, and then I have a baseline that I can retest and see, is what I'm doing effective? So that would be probably my ideal. But, you know, it's not a cheap test by conventional lab testing standards. So if I'm going to get just an advanced lipid panel to see where are we, I would probably just start with it's the lipid and then the homocysteine, lipoprotein A. If I could get like a small dense LDL or an MMR, which is NMR is showing us particle size. I would like to see that, you know, maybe you have a high LDL, but then it comes back that all your LDL are big and fluffy. I'm not real worried. If they're small and dense, we have something to work on. Yeah,
the big fluffy ones are the
safer
ones.
Yes.
I almost get it backwards every time.
Yeah, small dense, think about it like a projectile. A small dense projectile is going to penetrate deeper than a large fluffy cloud. Okay. And the thing that the small dense LDL is penetrating is the wall of that artery. And then we have the inflammation cascade, and now we have the white blood cell coming over there and phagocytizing the oxidized LDL, ultimately making a foam cell, and that's what builds up our plaque. And the plaque's not on the inside of the artery, most innermost layer, it's in the wall. And so as that inflammation continues to happen and the plaque continues to grow, that's where we see the diagram, where it just starts with streaking in your 20s, and then it goes and goes and goes until it's quite large, taking up a significant portion of the artery, and it can ulcerate. And that's when we generally have a heart attack. It's like it looks like a zit that bursts. And so that's when we have problems. And then you get to come see the cardiologist in the cath lab.
Yeah,
so.
And that's whenever they get the big STEMI and everything.
Yeah, potentially a STEMI, and you get to be rushed immediately back there, and they're going to run a tube or a catheter through hopefully your wrist, possibly your groin, up into your heart, and then we're going to be looking at, where's this blockage, how big is it, and can we put a stent there to save your life, or is it that you have plaque everywhere, all three coronary arteries, and now you are not really a good candidate for a stent. You would be better served by bypass, and you get your chest sawed open, and we get to sew new arteries, which it's a lot easier to prevent that than have to go through it.
Yeah. So that being rushed to cath lab, as I've done it a lot of times in the ER as a nurse practitioner, and there's just always, it's scary every time, and sometimes it's a lot worse because they'll go into ventricular arrhythmias. I've had to one guy, he was just he would just go straight up to VTAC, and then he would just pass out, and we'd shock him, and he'd wake up and be like, "Stop freaking shocking me!" and then you'd see it like start running again, and he would slowly just kind of go back out, and you shock him, and every time he was just so pissed, and it was like, oh man. One time we were doing one going up in the elevator. The elevator's always the scariest part of the hospital.
That's ICU flashbacks. Like I've got all my equipment and a super sick person in a very small space. It's not fun.
We've done a CPR, and like the kind of the same deal. The guy would go unconscious, do CPR, to wake up while you're pushing on his chest, you're perfusing it.
Yeah.
And then you'd stop and, they just literally die. It's just like going to the cath lab's always a bit of a butt puckering process.
Yeah.
It's not always that
well,
dramatic.
even if you're in the cath lab, I mean, that's the best place to be if something's going to go wrong. But even when people start going into, lethal arrhythmias, it's not a lot of fun.
Back to the cholesterol. ApoB, does that correlate enough with LDL that you can just follow ApoB, or is there ever any type of discordance?
I don't know that I could say that, but I do like ApoB better. I feel like ApoB is a better measurement of plaque or cholesterol that is atherogenic and going to make plaque. I think it's a better measurement, and I personally like to use it with a ApoA1. ApoA1 is kind of a better marker of good cholesterol, and we can make a ratio. So if your ratio is above 0.7, then you're at a higher risk for cardiovascular risk.
And are there anything, like I think we've talked about it in the past, but like, niacin would raise HDL, but it never really changed outcomes. Like with the ApoA1, is there anything that we like, okay, it's off, so now what do we do?
Yeah, so it's another indicator that we need to decrease sources of inflammation, and again, we need to decrease the visceral fat. Decreasing the visceral fat by increasing the physical activity, increasing the intake of good, healthy foods, eliminating the processed, that's going to help to raise the HDL in a meaningful way. Whereas, like you said, with drugs, I like niacin, but drugs like niacin and that were shown to increase HDL, it didn't reduce mortality. In fact, there were a few drugs that raise HDL where mortality actually increased. So we can't do it with a pill. That's up to you.
The benefits of niacin that you see, is that independent or different than raising the HDL, or what do you like niacin?
I like niacin because it can help lower triglycerides. I have some people in my previous practice that they had sky high triglycerides and genetic predisposition, but regardless, we still need to manage those. And so in addition to managing blood sugar, which is a huge driver of triglyceride, because triglycerides are a way to store sugars and fat that are in excess. We need to save them for later. You've eaten too many carbs, and so your body's taking them and stuffing them away in your fat for later. And so we need to, probably change the diet. For sure, change the diet. We need to maybe give high quality omega-3 fish oil is a very powerful way to lower triglycerides. Alternatively, you could eat sardines 3 times a week, but almost everybody makes a face when I say that. And then we might have to consider other things like fenofibrate, or in that case, adding some niacin. Also,
is fenofibrate still, I haven't kept up enough to know, is that still one of the main ones?
Yeah. Yeah. Some people use gemfibrozil. I'm not a big fan because a lot of people are on statins, and I don't like them in combination. There's just more side effects, I feel like, with gemfibrozil, and so I go with fenofibrate. But that's if it's not already managed with the high-quality omega-3 fish oil, which for a large majority of people seems to get the job done. So you may not need all those extras. And then the other benefit of niacin is it does help to also reduce lipoprotein A a little bit. Eliminating polyunsaturated fatty acids from the diet also does that. So I would do anything I could do to help reduce that number, although we do need to have a significant reduction to see a clinical significance.
Yeah, because right now, really, it's only PCSK9s that do it
and
predictably.
Small interfering RNAs like Leqvio, which just works a little bit more upstream than like a PCSK9 like Repatha. But yeah, so they do, I think Repatha reduces lipoprotein A by about 26%. We really need like a 90% reduction. So there are drugs that are in phase 3 clinical trials to specifically target lipoprotein A, but they're not available yet.
Oral estradiol specifically can modulate Lp(a), and we just don't have studies like in women, postmenopausal women. Of course, it helps with cardiovascular protection. We see that a lot, but in guys, we just don't really have the studies that I'm aware of to show like, okay, can this? And I know some guys in the kind of longevity space that take it that do have elevated Lp(a). And so, I mean, it's like 3 that I know of. So it's not going to be any, and I won't know in my lifetime what their stuff is, but I kind of hope something comes from that. But one of the other things, I'm going to switch to homocysteine, because that's not like a fatty particle. Or what is homocysteine?
No, homocysteine is a byproduct of methylation and methionine metabolism. So what that means is it's a very basilar or foundational process that your body has to undergo. But whenever you have issues with metabolizing folic acid, then we can see the homocysteine levels rise. It's a byproduct or an intermediary kind of substance that's converted back to something else later. But it's at a high level, it's almost caustic to the vessels. And so elevated homocysteine levels or hyperhomocysteinemia, we see increased incidence of cardiovascular disease, stroke, dementia, and for women, obstetrical complications. And many times there is a genetic component to that, which is MTHFR, which is kind of got a lot of notoriety lately. But it just means that you have an issue with you genetically. You have a sluggish or impaired MTHFR gene. And so really, I don't think anybody should be taking folic acid or eating folic acid like from fortified grains because we're not rats. Rats and mice have a different ability to process folic acid where we don't have that. So we should really be prioritizing the folate, which is the natural form. The other thing people don't understand is that the folic acid competitively binds the receptor. So it can kind of, even if you are taking a folate, but you're eating a high enriched wheat flour diet, you're probably limiting the effectiveness of that.
Do you like to have the MTHFR testing? I mean, what I've been doing, somebody asked me about it, I bet once a week. Mm-hmm. And typically I just say, like, look, I assume everybody or most everybody has some sort of MTHFR deficiency. Let me just check a homocysteine because that's kind of the end product anyways that I care about. So it saves them like $500. It's not as...
Yeah, you don't have to have genetic testing. We can do the homocysteine, get an answer, and implement the strategy, which is to give them a methylated folate, L5-MTHF. So I agree with you, and what people kind of don't know is about a third of the population has MTHFR.
Okay, so about a third.
Yeah, so I would agree, like, do we need to genetic test a third of the population? Probably not. Like, we can find something actionable and roll with that.
Because it is making its rounds because people message me about it, and it's an expensive test, and homocysteine's not. I mean, it's somewhat, but it's like, the MTHFR is like $500-600. Homocysteine's like $40.
Right.
It's just and so it's like, and it's more actionable to me because then I'll be like, here's our methylated B complex with methylfolate in it.
Yeah, and I like a methylated B complex more than taking just isolated B vitamins. I think it's an easy way to get an imbalance if you're just taking like, I'm taking a B6 and I'm taking a B12. And, I think they're in balanced ratios when you take it from a methylated B vitamin. As far as homocysteine levels go, like I have this. I have the MTHFR. I've actually done the genetic testing to say it, but initially mine was like 19 or 22, which is
mine was
really
like
high.
18.
Yeah,
as well.
So I started taking a good amount of methylated B vitamins, and I've got mine down to 7.9. Optimal is in the 7s. We really want it less than 9.
Okay. And so I'm going to even kind of switch gears to the next step. Like, okay, now somebody is like, all right, these are all kind of out of whack. Nothing is really falling where we want. Do you like to get any imaging, like a coronary CT, or let me start with a calcium scan or a carotid scan? Do you utilize either of those?
I would like to. I've been looking into how can we implement or where can we send someone to get the carotid intimal medial thickness. I think that's a pretty good way to kind of see what's happening. All the vessels are one big highway. So, I mean, if you have an increased thickness, we know that you have endothelial dysfunction and you're likely laying down plaque. And if you're laying it down in your neck, you're probably laying it down in your heart or your brain. And so I think that's good, and I would be interested to be able to offer that in the future maybe. And then, yes, we can do a coronary artery calcium. They're a little bit nuanced. I think they're good for trending, but if I just had one and never checked it again, I don't know that would be as useful. Now, if you get a 0 on your coronary artery calcium, then you have a low risk of any, cardiac events in the next 5 years. But it's telling us about calcified plaque. Calcified plaque is generally stable, where we're not really getting a picture of the soft plaque. The soft plaque can be the plaque that ulcerates or migrates and causes a heart attack. So it's giving us somewhat of a picture. Now if you had a 400 coronary artery calcium score, now I'm going to be a lot more aggressive in evaluating, like, where is the buildup? Is it in your LAD, the front artery that feeds the the powerhouse of the heart, the left ventricle? Then I'm going to be a lot more aggressive. And at that point, if I had that elevated coronary artery calcium, I would very strongly think about maybe doing a coronary CT angiography. And that's about the best option to visualize the coronary arteries without actually having to take you to the cath lab and invasively go in and look with a heart catheterization. So.
With the another nuance to just the calcium scan, 2 questions. I think it's like 20% of a score of 0 may still have kind of the soft plaque or other meaningful plaque deposition. And then another thing with it, do you have any insight, like endurance athletes will get elevated calcium scans, but they're still stable, or what's with the athlete part
so
of it?
I've seen where they show that high performing athletes have higher coronary artery calcium scores. I think that maybe the general consensus maybe isn't totally finalized as to why that is, but I think that's why it's nuanced. I think that we have to look at the patient in front of us and correlate clinically with what's going on, because it can be manipulated somewhat.
But if it's high, then it is nice, because I think I saw one of the things said a calcium scan of a score of 400 is equivalent to previously having a heart attack, and it should be treated from then on almost as secondary prevention protocols rather than just staying primary prevention, even if the guy is asymptomatic. Have you seen that, or how would that change your treat? Or would that just...
I would be very aggressive if you were over 400, because that's a pretty significant amount of...
Yeah.
And I've seen people way higher than 400. So, I've seen people that have coronary artery calcium scores of 3,000. And it's you have major multivessel coronary artery disease. Are you even a candidate for a bypass? Because you probably don't have any distal targets. It's not good.
And were they asymptomatic?
I have some they were all very low physical activity and usually smokers. So, you can kind of fly under the radar with symptoms if you're a very sedentary person. That's another reason why I would always tell my patients, not only for your longevity, but for me, I would like you to walk, because I'm going to be able to pick up on symptoms way sooner if you're walking that 30 minutes, 20 minutes, 15 minutes, and then all of a sudden you're doing well with that, and then you fall off a cliff and you can only do 10. Something's changed. We need to go look.
So it's a mild stress test every day then.
Exactly. Yeah. Plus, you can build up your collateral circulation with walking, not only in your legs, but in your heart.
And then, so whenever you do get what basis to get the coronary angiogram with contrast and stuff? When in a healthy asymptomatic guy, I can see if they had symptoms or whatever, but when would I
really strong risk factors?
Gotcha.
Yeah. Really, whether that's family history, or their personal history, or especially if they have diabetes, or maybe they lived, maybe a less healthy life. Now they're trying to get healthy. So they smoked, they drank, they dipped snuff, whatever, and they had some glucose intolerance or pre-diabetes. I think that's reasonable let's make sure that they don't have any major issues with their plumbing. Now, if that same person is able to go and do high intensity interval training, they just jumped in without consulting and they've been able to do it, well, maybe their functional capacity can make me feel a little better about the situation. But I do lean towards the test don't guess. Let's go ahead and screen you. Let's get a baseline. Let's see if you have a 40% stenosis. It's not significant enough to require a stent, but we know it's there. Now let's be extra aggressive and prevent that from progressing or possibly even seeing some regression in plaque.
So plaque can regress.
Soft plaque can regress. I'm not going to promise that to everyone. I think it takes like significant lifestyle change and really good cholesterol management and reduction of sources of inflammation that are causing endothelial dysfunction. But when you do all those things right, then yeah, you can see.
How long is that, like a year's process or
Years?
Yeah.
Mm-hmm. Yeah.
And then two other like non-fun things with the coronary angiogram. They give you nitro and like a beta blocker, right?
So if your resting heart rate is like more than 65, then you're going to get a beta blocker to slow you down. We want to get optimal imaging, and we'd like you in the 50s or 60s to do that so that the high definition CT scanner can capture the heart still on those slices or images. And then we give the nitro to, open it up and get good imaging with the contrast.
And then the Clearly protocol or algorithm, or what is that?
So I would like to, be able to offer or direct somebody to a facility close to here. Unfortunately, in our city, like, we don't have anybody doing Clearly analysis on the coronary CTA, but it's software enhanced with AI that further evaluates hard, soft plaque, and it gives us a lot more information. So
nice.
I think it's superior.
So now that we've kind of gone through like a workup, this patient is back, and now what do you like? And we've beat to death lifestyle every time we've seen them each time. But now what are we doing alongside a high risk individual for treatment overall?
Yeah. So for treatment, if we are in addition to all the foundational things, I definitely offer my patients some supplements that are shown to have benefit in reducing cholesterol and improving health metrics, like berberine or bergamot. The high quality omega-3 fish oil are a few, and then kind of see where we're at. But if they are really high risk, then maybe we need to take a closer look at adding on something like Zetia, or do they qualify for a PCSK9 like Repatha, depending on what their lab work looks like.
Is there any way to get Repatha covered easily for primary prevention?
I'm not aware of that.
It's just not.
It's just kind of expensive right now.
Yeah, so. Yeah, and that's the hardest thing, because it's like spend all this money on cholesterol that you can't see or feel. Like you don't feel any benefit from getting your cholesterol to better manageable levels. And so for management, one thing I'll bring up, you didn't mention any statin right off the bat. Why and what is this huge controversy with statins? Why are they so hated whenever they're cheap and they lower cholesterol?
Yeah, so I'm probably like the black sheep in cardiology. I'm not a huge fan of statins. I'm not saying I don't use them. I have used them, but I like to kind of let the patient decide which route they're going to take. Do they want to take I'm going to change my lifestyle, I'm going to change my diet, I'm going to do the exercise, I'm going to put in the work to change my life and reduce my risk, and I would like to maybe avoid just going straight to all the pharma options, and let me try these supplements as well and kind of take more of a holistic path. Now there's also people that don't want to do that, and they would prefer to just follow the traditional Western medicine guideline. Maybe they're not interested in changing their lifestyle, they're going to continue to smoke. Then we'll go ahead and follow that pathway and put you on a statin.
Why are they not your preferred? Like what's the bad thing about them?
So I think patients hate them because many times they experience fatigue or like muscle aches, joint aches. But I'm not a huge fan in that the absolute risk reduction isn't that impressive to me. Dependent on the risk, your absolute risk reduction is somewhere around 0.7 to 2.2%. And then your risk of developing diabetes is about 2.2%. So if we're going down a road by taking a medication that is leading to metabolic dysfunction, which can cause endothelial dysfunction, like, are we really going the right way? It seems antithetical.
Like literature-wise, it says that side effects are only like 2 to 4% of individuals.
Anecdotally, it's higher.
Yeah.
For my practice, I would say it's much more than that, personally.
Just most people, or like, they just seem pretty intolerant.
Yeah.
Does So we're typically like here at Live Oak and everything, we're talking primary prevention, keeping healthy people healthy,
Right.
and keeping them, out of that as much as we can. But let's say someone has had an event or something. Now we're more secondary prevention, more damage control. Does that change your willingness to use them much?
I'm not unwilling to use them. I also don't ever want to tell somebody you're going to be on this medicine for the rest of your life if they are willing to do the work on their end.
Yeah.
So I think there's a world where they can drastically 180 change their health, specifically metabolic health, and maybe we don't have them on all those medicines for the rest of their life. But am I going to pull someone off of their statin 6 months after they've had an event? No.
Yeah.
So
what about aspirin these days for primary prevention? What's up? Do we bring that on for healthy people or?
Yeah, so I like aspirin, and it's not just for the cardiovascular effects. There's an anti-cancer component to aspirin. And so, again, depending on risk factors, maybe it's not for everybody, and that's why there's not a blanket recommendation for everybody over 12 to take aspirin.
Yeah.
But I think it's not a bad idea to consider taking aspirin if you don't have an issue with reflux or you have some other bleeding problem. The risk of bleeding is low, and so but the benefits could potentially be greater.
Just normal 81, not full 325.
Yeah, there's no reason to take anything more than an 81 in regards to cardiovascular health. The 81 irreversibly binds platelets, and so when a platelet is irreversibly bound, giving more aspirin is not going to bind it anymore. It's like Super Troopers. Like, I can't pull over any farther, man. So, it just increases your risk of GI bleeding. So just go with the 81 every day. That's fine.
And is that still like a healthy person over 55 with nothing else? Still like it's not going to hurt anything? Or
it's not going to hurt anything.
And
if you do have, some bleeding from your gums, or you have an occasional nosebleed, or you start to notice some black or red in your stool after starting it, stop it.
Yeah.
Okay.
Why is ezetimibe and PCSK9 a little bit better? Like you're more willing to do those over a statin.
Yeah. So, Zetia works more so in the gut to limit the cholesterol absorption, and the PCSK9 has a very clean side effect profile, very, very low side effects because it's working so specifically in the body. The more specific the medication is, kind of the less other body systems it affects, and therefore the less other side effects. So that's why I'm more willing to use a PCSK9 because the risk of side effects is much lower.
Yeah, and I kind of forgot during the workup, but we've talked about there being hyper producers of cholesterol versus hyper absorbers.
Right.
And so like ezetimibe works amazing for these guys that are hyper absorbers because it blocks it in their gut.
Right.
Do you ever get that lab? Is that because that's a genetic test?
So that's
right?
on the CardioZoomer from Vibrant, but that's the only time that I will get that test is if I'm getting it with the CardioZoomer.
Okay.
So I kind of have, we can do the advanced lipid, it won't be on there. Or we can go get the full amount of information and it'll be there.
I've had several patients that, fall under the lean mass hyperresponder category, which is kind of like a guy that looks metabolically healthy, is active, his markers are good, his fasting insulin's like 4, or 3, and, works out every day, but LDL cholesterol of 200. He's adopted. We don't know family history. Doesn't smoke. How do you look at this lean mass hyperresponder population?
Yeah, so it's funny because I had actually asked Dr. Twyman this question on a live on Instagram that maybe not this exact question, but if you're metabolically healthy, does high cholesterol matter? Do we not need to worry? And his question was like a resounding, absolutely not. We need to worry because metabolic dysfunction isn't the only driver of endothelial dysfunction or a damaged glycocalyx. So, and I thought that was, pretty insightful. So, but it does reassure me somewhat if I can see that your, fasting insulin's less than 5. But I would like to get more information to decide if that is acceptable or is it not. The analogy I had made earlier was driving down the highway, like, at 70, we can make a correction. At 200, we don't really have any time to make correction. So if you are laying down plaque and you're one of the hyper responders running down at 220 on their LDL, we might be in a bad situation. So we should look further into that and see if we are still having a problem, maybe not from metabolic dysfunction.
My biggest worry with them, like that guy, those guys specifically that are actually metabolically healthy, make me less worried. But I think guys inappropriately put themselves as metabolically healthy, and they're like, "Oh, my LDL is 180," but social media said I didn't have to worry about my cholesterol at all because I'm metabolically healthy. And then it's like, bro, your hemoglobin A1C is 5.9,
right,
and you're 20 pounds overweight.
Right, so you're not.
And
really, truly, like 90% of Americans have some form of insulin resistance. So if you are truly insulin resistant, we're still not out of the woods. So in all probability, we probably need to adjust your diet somewhat, because it seems like if we add some carbs, healthy sources of carbohydrates back in, that sometimes that'll come back down. And but at the very least, we need to do further evaluation.
What are your healthy carbs that you like to implement?
I really push fruit, a lot of fruit, sweet and non-sweet fruits. You can do squash and cucumber. I will tell people to throw in some vegetables like carrots or arugula or whatever. I try to maybe avoid things grain heavy. So not telling people to eat a lot of breads, not telling people to eat a lot of oats, things like that.
So just to close, we'll do a couple rapid fire questions. Don't need long answers or anything, but just most overrated heart metric.
Total cholesterol.
Most underrated metric.
VO2 max or functional capacity, heart rate variability, blood pressure, advanced lipid panel. And
then which test do you think PCPs and your primary doctor under orders?
Fasting insulin. It's pretty easy to order that right alongside your hemoglobin A1C. They're fasting anyways, most likely. It's pretty insightful.
One lab that gets overinterpreted.
LDL. Send people into a panic before we really have a full picture.
Gotcha. And then what do you feel is the earliest sign of insulin resistance?
So fatigue after meals, increased abdominal circumference. Maybe the more dramatic presentation would be like acanthosis nigricans, where you get that kind of darker pigmentation around the kind of neck lines or folds, skin tags, things like that. But most of the time it's the feeling sleepy after eating or just low energy in general.
And then what do you think is the biggest heart health myth?
That Cheerios and canola oil are heart healthy for you, and saturated fat and sunlight are bad for you.
Gotcha. I like it. Well, thanks for coming on. Thanks for weathering through the Live Oak podcast time.
Yeah.
And we are going to be offering VO2 max testing, advanced lipid panels, and further cardiac insight. If you want to reach out, text or call, make an appointment. And of course, if you have any questions about any of this or any topics you want us to cover, reach out and we'll be happy to cover them.